All right, so one thing I can promise you guys about my section is I will not sound as smart as either of my two colleagues who you just heard from. So my task in all of this was to talk about some of the systemic adaptations that we get looking at both resistance training and from the endurance training end of the spectrum, okay? So one of the things that I want to touch on initially, we're going to talk about ventricular remodeling a little bit and arterial stiffness. That's something that comes up a lot on the forums. I think there's something on there. There was something on there just recently about, people have this idea that if they do too much resistance training, their heart is going to become enlarged or their arteries are going to become stiff and they're just going to drop dead at any moment from some type of cardiovascular event. We're going to talk about cardiovascular function from the standpoint of cardiac output and blood pressure, and we're going to talk about oxygen utilization, VO2 max, peak VO2, and EPOC a little bit as well. So when we're talking about ventricular remodeling, there are a few terms that you should be familiar with. So terms that you'll see in the literature are physiologic hypertrophy, which is what we know to accompany chronic resistance training. That's different than pathologic hypertrophy, which is what accompanies things like chronic hypertension, chronic heart failure, and hypertrophic cardiac myopathy, okay? And really the difference between these things is that when we have increased left ventricular wall thickness as a result of chronic resistance training, the size of the cavity of that left ventricle remains the same. Whereas if you have chronic hypertension or hypertrophic cardiac myopathy, what happens is that wall gets thicker, but the cavity size gets smaller, okay? And that's where these kind of problems come in. So we know that the large acute increases in systolic blood pressure that we see with chronic resistance training does not lead to any of these chronic problems that occur in pathologic conditions. Other terms that you'll see very often, so concentric hypertrophy, you can kind of think of that in the same way as that physiologic hypertrophy, okay? So just something that in the literature you'll see commonly associated with chronic resistance training. And again, that's just referring to increased thickness of the left ventricular wall. Versus eccentric hypertrophy, which is a term that is very commonly associated with chronic endurance training. And that is really a widening of the ventricular cavity, okay? But, in reading the literature on this stuff, it became very clear that it's not as cut and dry as maybe they make it sound in ex-phys textbooks or, in maybe some courses and things that you might have taken in the past. In looking at the research in aggregate, it does appear that resistance-trained individuals do have a mean increase in left ventricular wall thickness in comparison to endurance athletes, okay? But when we look at these changes in comparison to normal untrained subjects, it doesn't become, that thickness doesn't go beyond what we would consider normal, okay? We're basically going from normal to the upper end of what we would consider the normal range, okay? So there's nothing pathologic about the thickness of the ventricular wall in response to chronic resistance training. Now, what kind of complicates things a little bit is that we see in some endurance athletes like swimmers, rowers, cyclists, wrestlers are kind of a combination, right, of endurance and or aerobic and anaerobic type stresses. And I guess depending on the types of events in rowing, cycling, and swimming, you can have various types of demands as well. But we see increased thickness in the ventricular walls in those athletes as well, okay? So it's not just power lifters, weightlifters, and things like that where we get these types of changes. And on the other end of the spectrum, we see in strength athletes, they can also have an increase in the size of the left ventricular cavity, okay? So these changes are not just purely on one end of the spectrum or opposite ends of the spectrum, kind of like Sully was alluding to earlier this morning. So just in total, things are not as cut and dry as we may have been previously led to believe. But really the take-home point is that there is nothing dangerous about the changes that we get in the ventricular wall in response to resistance training, okay? When we look at arterial compliance, so the term arterial compliance is referring to the amount of stiffness that we have in our arteries, okay? And that is a consequence of normal aging, okay? And basically, you know, we can be pretty confident the more stiff you are in general, the more stiffness you're gonna have in your arteries to a certain degree, okay? Now, there is an association between increased risk of cardiovascular events and increase in arterial stiffness. Now, when we look at resistance-trained individuals and arterial stiffness, that relationship has been very inconsistent to this point in the literature. We've seen studies where they've shown increases in arterial stiffness, and they say, well, this is a dangerous thing. If people who resistance train obviously are going to have an increased risk of cardiovascular event because of this increased stiffness. We've seen increased stiffness where the authors will say, well, yeah, that makes sense. They're dealing with higher pressures. It would make sense that their arteries become a little bit stiffer to deal with that, and that may be a positive adaptation to resistance training. We've seen resistance training shown to have a decrease in arterial stiffness or an increase in arterial compliance, and then we've seen no change at all. So it's really hard to make any concrete assumptions about, you know, the response of our arterial compliance to resistance training at this point. Now, what are some of the problems? Well, like all of the resistance training literature, there's so much variation in terms of the protocols used. Sully talked about this earlier. You know, just look at the rest intervals used in some of these studies where they're looking at resistance training adaptations. But if you're giving people 30 seconds of rest or 1 minute of rest, that's a lot different than taking 5 minutes in between your set of squats, right? And then the methods utilized to measure arterial stiffness can vary a lot from study to study. So that can have an impact on the results, obviously. The most recent article that I could find was from Stuart Phillips' research group, which if you guys remember from last year's panel discussion, that Morton article, that's the same research group, okay? So they basically took that same resistance training protocol, high load, high load, low rep resistance training and low load resistance training, and they looked at the effect of both of those types of programs on arterial stiffness. And what they found is that both of them resulted in a decrease in arterial stiffness. So whether they were doing higher repetition low load or lower repetition high load resistance training, they found a decrease in arterial stiffness in both groups, which, you know, sounds like a good thing, but again, there's so much kind of variation in the conclusions in the literature that we really can't, you know, get overly excited about just that one paper, even though that's, you know, the most up-to-date one that I've seen. So moving on from that, we're going to talk a little bit about cardiac output and blood pressure. So the term cardiac output, what that really is referring to is how much blood your heart is able to pump in a given time period, okay? And how we arrive at cardiac output is really just taking your heart rate, okay, and multiplying that by your stroke volume. And your stroke volume is just the volume of blood that your heart pumps out in any given contraction, okay? Now, an increase in cardiac output is really one of the more significant changes that we see with endurance training. And we see that increase in cardiac output primarily as a response to improvements in stroke volume in endurance-trained athletes, okay? Endurance-trained athletes get better at pumping out large volumes of blood with every contraction of their heart. On the other hand, submaximal cardiac output is actually reduced in endurance-trained individuals because they're more effective at distributing blood throughout the body, right? And the trained muscles increase capacity to generate ATP aerobically. So earlier, Sully was talking about that aerobic energy system. You know, we know that they're more efficient then at using their oxygen to supply ATP to their working muscles. Now, in regards to blood pressure, what blood pressure actually is taking your cardiac output and multiplying that by your systemic vascular or peripheral resistance, okay? Now, anything that increases your heart rate stroke volume, or resistance to blood flow in the body is going to result in an increase in blood pressure. So what that means is that any type of resistance training, endurance training, or high intensity interval training is all going to lead to increases in both cardiac output and blood pressure, okay? The harder the muscles contract, the greater the increase we have in terms of systemic vascular resistance. So this is what causes that really large rise, particularly in systolic blood pressure that we see with resistance training. And the left ventricle has to work harder then to push blood out of the heart and get it to the working muscles. That pressure is what we refer to as afterload, all right? And that's tied into, again, that ventricular remodeling that we talked about earlier, okay? Now, what's going on simultaneously as your muscles are contracting and you're using the Valsalva maneuver, we have that increase in intrathoracic pressure. That compresses the large veins, and that reduces blood that's going back to the heart at the same time. So it's harder for the blood, it's harder for the heart to pump blood out, and then it's harder for the veins to return blood to the heart simultaneously. That leads to a decrease in what we call preload, okay? And that further increases your systolic blood pressure. So when we look at Dr. Baraki and why, this explains why his eyeballs sublux while he's doing something like a heavy deadlift or squat. So he's got that increased pressure from his muscles contracting, using the Valsalva maneuver. Blood is actually backing up in the veins. That's why they're bulging out of his neck and everywhere else. That's really a result of that decreased preload that goes on during heavy resistance training, okay? Now, how long the Valsalva is held for has an impact on all of this. And Austin and CJ actually wrote a really nice article on this, and obviously I hope you're all familiar with Sully's article on the Valsalva maneuver. But the longer that the Valsalva is held for, it has an impact on this stuff. So what happens initially is blood pressure and stroke volume are going to increase while the heart rate remains steady. Now, after about 5 seconds, we get a decrease in blood flow back to the heart. Now, most of us, repetitions of resistance training don't take more than 5 seconds. If you're like me, my last warm-up takes more than 5 seconds, so I would fall into a different category. But a lot of the research that's been done on Valsalva maneuver is looking at, these prolonged holds, and really that doesn't apply to what most of us do from a practical standpoint, right? We're holding our breath for a couple seconds while we exert, we exhale, we take another breath, and then we do our next repetition. But basically, after about that 5-second mark, we get increased thoracic pressure and decreased blood flow back to the heart. As a result, stroke volume, blood pressure, and cardiac output all go down. And that requires a simultaneous increase in heart rate to keep the blood pressure within normal limits, all right? Now, in terms of what this all means, a lot of this is describing what's going on from an acute standpoint, all right? This is what's going on while we're actually training. From a chronic standpoint, the increased strength that we get from resistance training has a really profound effect on making all of our daily activities easier, right? And we've seen that a couple years ago. We reviewed a paper where we looked at the effect of resistance training on people with CHF, with chronic heart failure. And resistance training didn't improve their CHF, but what it did was it made their ability to perform activities of daily living easier. And that's really what we get from resistance training. So that makes all of our tasks a little bit less stressful on our cardiovascular system to a certain degree. I live in the Northeast, and every year there are people that die of heart attacks shoveling snow, right? When they go out to take care of their driveways. These are sedentary people who are weak, atrophied, probably have multiple cardiovascular risk factors. So them trying to recruit all that muscle mass, exert all that force, that's a recipe for disaster. So being stronger obviously leads to our activities of daily living becoming easier, which is a nice thing, and makes those activities less stressful on the cardiovascular system. And chronic resistance training results in reductions in resting heart rate, systolic blood pressure, diastolic blood pressure, across a variety of populations. And like what Sullivan said earlier, these things are more profound in untrained populations, right? If you have a highly trained endurance athlete, adding in a little bit of resistance training is not going to have a big impact on, you know, some of these markers of cardiovascular health or aerobic or cardiovascular efficiency. But in an untrained population, it really can. Okay, so VO2 max and VO2 peak. So what VO2 is basically the highest amount of oxygen that we can supply to our muscles despite ever increasing exercise intensity, okay? So what happens is at a certain point, you cannot continue to supply more and more oxygen to your muscles even if exercise intensity goes up. That would be a true VO2 max, okay? A VO2 peak is what we use to describe a situation where we get to a point where oxygen uptake, we really can't get to that true VO2 max. And usually that is a result of local muscular fatigue rather than an inability to continue to supply more and more oxygen. So if you take somebody who, let's say they're a cyclist and you throw them on a treadmill to do a VO2 max test, well, if they're not used to running, you know, their fatigue from doing an unfamiliar activity may prevent them from working harder rather than their ability to aerobically, you know, supply their muscles with oxygen. What's interesting about VO2 max is that it indicates someone's ability to aerobically supply their body or resynthesize ATP to their muscles, okay? Exercise that's performed above VO2 max, okay, once you cross over that threshold, now we have to get into those different energy systems like Sully was talking about earlier, and we get into that anaerobic end of the spectrum. But what we know about that, the anaerobic end of the spectrum, we can't do it for a prolonged period of time, right? So if you're trying to perform an endurance type activity above VO2 max, you're going to start to have lactate accumulate, and exercise performance is going to start to quickly deteriorate. You know, one of the things that when we were talking about bioenergetics before that you saw is that the aerobic energy system produces a lot more ATP than the anaerobic energy end of the spectrum. The anaerobic system, the benefit of it is that we get the ATP faster, but we get a lot less of them, okay? So similar to some of the other stuff that we've talked about, if you have an untrained population and you put them on a resistance training program, you can see an actual increase in VO2 max and some of these numbers. In a more highly trained population, you're not going to see those types of adaptations. I would say an average VO2 max is somewhere around 40 or so. Would you guys agree with that? It depends on the population, right? So in a healthy, younger population, maybe somewhere around 40. Well, for a highly trained endurance athlete, it's going to be 60 or above. Yeah, or way above that. So, you know, the difference in response from resistance training is going to be obviously different from a more highly trained population than an untrained population. EPOC. So EPOC stands for excess post-exercise oxygen consumption. And we have a little bit of a different response to resistance training and endurance training when it comes to this stuff. Basically, after you exercise, whether you're doing endurance training or your resistance training, your bodily processes do not just go immediately back to the pre-exercise resting levels, okay? And recovery time is largely dictated by exercise intensity, not as much from exercise volume, okay? So what EPOC is specifically talking about is the total amount of oxygen consumed after exercise that is in excess of your pre-exercise oxygen consumption levels, okay? So how much more you're taking in after you exercise versus what you were taking in at your baseline. So when we're talking about EPOC, there are two components to it. One that occurs very quickly and one that is more prolonged, okay? So in low intensity aerobic exercise, where we don't see a big increase in body temperature, most of EPOC, about half of it occurs within 30 seconds or so, and complete recovery only takes a few minutes. at higher intensity exercises, so things like we would expect to see with high intensity interval training and to a certain degree resistance training, there's a slower phase that occurs. Now, in the ex-phys textbooks and things like that, you'll see that it'll say it can take 24, up to even 24 hours. In the papers that I've read on EPOC, I didn't see anything that approached that time. But there still is a slower component that occurs. So when we're looking at these things, one of the things that's kind of interesting is that the higher intensity, more intermittent exercise may favor increased lipid oxidation rather than, or in comparison to what we see with steady state aerobic exercise. Now, because resistance training, like Dr. Sullivan talked about earlier, is more intermittent in nature, we would kind of think that we would get a response in terms of EPOC that is maybe more similar to what we see with high intensity interval training rather than what we would see with steady state aerobic exercise. And what we've found is basically we do get significant elevation in EPOC anywhere, depending on the study that you're looking at. I've seen 60 minutes up to 120 minutes. So anywhere from an hour to 2 hours post resistance training, and that's the same for men and women. We do see, an increase in EPOC, and we have basically a favoring of lipid oxidation. So especially when compared to sedentary controls. Now, how important is that in the big scheme of things, that you're using more lipids after you exercise for that hour or two? Probably not that clinically significant, I would say. So when we're looking at similarities and differences between resistance training and endurance training, I think it helps to kind of break things down. One, look at the endurance training end of the spectrum, and then we'll look at the total opposite end of the spectrum, which would be purely in isometric type activity. And resistance training is going to fall kind of somewhere in the middle there. So when we're doing endurance training, the primary cardiovascular responses we're going to see are going to be increases in cardiac output and heart rate and VO2, which kind of parallel the intensity of the activity. Okay, so if you're going for a walk, your heart rate is going to increase mildly. If you're doing a harder run, obviously it's going to increase in proportion to the intensity of what you're doing. Similarly, so stroke volume increases initially and then eventually plateaus. Systolic blood pressure increases. Diastolic blood pressure, really, it may increase a little bit, but it's pretty much going to stay, or it could even decrease slightly. Systolic blood pressure is where you're really going to see the larger change, or you should in a healthy individual. And then what's going on with endurance training is that we're taking blood from less active tissue, and then the heart has to now supply that to the working muscles. And because of that, we kind of refer, or you see endurance training referred to very commonly as producing a volume load, okay? So the heart has to meet the demand of the muscles by pumping out more and more blood, okay? Now, in contrast, on the opposite end of the spectrum, if we're talking about something that's purely isometric, we see increases in heart rate, systolic blood pressure, and diastolic blood pressure proportional to the force that's exerted, okay? Relative to the maximal amount of force that a person's capable of producing, all right? So cardiac output may increase a little bit, but not much increase in VO2 max, all right? We wouldn't expect to see anything like that. And basically, what we see is a significant pressure load now being applied to the cardiovascular system, okay? So it's not so much about having to supply the blood to the working muscles, it's about how do we handle this increased pressure demand that all this force production is causing us to have. So when we're looking at the acute effects of resistance training in terms of cardiovascular responses, like I said just a minute ago, it's really a combination of those two things. It's a combined volume load and pressure load, because we still have to supply blood to the working muscles, but we do have to handle these very large increases in pressure that we're dealing with when you're doing a heavy squat or a deadlift or something like that, in comparison to something that's purely endurance-based. Now, the magnitude of that load is going to depend on a variety of things, right? The magnitude of the resistance, so doing a set of 20 is a lot different than doing a 1 RM. The duration of the muscle contraction, okay, as well as the intervening rest period. And again, you know, when you look at the resistance training literature, the rest periods are generally much shorter than we actually see in practice. So when we're looking at the chronic adaptations of the cardiovascular system, you know, there's a lot of variety, in part because variety in the population studies, whether we're looking at a pathologic population or a healthy population, the types of protocols used in terms of resistance training. You know, a lot of the resistance training studies, they're just a total mishmash of different exercises and sets and rep schemes, and there's no real rhyme or reason for what they're doing. So it makes it really hard to have very conclusive results about these things because there's just no consistency. And the level of training advancement of the subject. So we know, obviously, the more highly trained somebody is, the smaller the response that we would expect to see. Again, a lot of this stuff is done on untrained populations or an unhealthy population, and that's going to be very different to a more highly trained endurance athlete. And CJ is going to really get into, you know, the performance ramifications of all that stuff. Like Sully said before, untrained and elderly subjects have consistently shown to have more robust cardiovascular and aerobic adaptations to just a resistance training intervention. Some of that can be due to the rest periods, but I think some of it is just due to the fact that if they were previously sedentary, resistance training does provide enough of a aerobic stimulus or a stimulus to the cardiovascular system that you will get some positive changes to occur. So what about high intensity interval training? You know, it's very easy, or it's a lot easier to talk about resistance training on one end of the spectrum and then endurance training on the other end. Well, like we talked about before, high intensity interval training really crosses over, you know, all of these. And I think Sully did a really good job of kind of discussing this before, so we're not going to spend too much time on it. But, you know, despite the fact that HIIT seems to be much more anaerobic in nature, we seem to get more of an adaptation at the aerobic end of the spectrum, which would appear to violate, you know, the laws of specificity that we spend a lot of time focusing on in exercise physiology. And if that's the case, then why do we see, if resistance training is inherently intermittent and intense, you know, why do we see such a wide variety or such divergent adaptations in terms of the aerobic end of the spectrum when we're looking at high intensity interval training and resistance training? Now, high intensity interval training is kind of interesting because when we look at, in particular, I think the wide variety of protocols that are used. So one of the classic kind of high intensity interval training researchers is Tabata. You guys have probably all heard of the Tabata protocol, right? Well, that's 10 seconds of maximal effort work at 170% of your VO2 max, right? So if you're not working at 170% of your VO2 max, you're actually not doing a Tabata, despite what your group fitness instructor tells you, or, you know, whatever the case is. So followed by, well, it's 20 seconds of work, 10 seconds of rest for 8 rounds done in 4 minutes. Okay, now there are papers that are said to be about high intensity interval training where the high intensity part is like a 5-minute, you know, type of intervention. So, you know, how can you draw conclusions about something like a Tabata protocol at one end of the spectrum and something that's a 5-minute work interval, which we know inherently cannot be all that intense, and still call both of those things high intensity interval training? So I think that confuses things more than anything, or clouds our ability to really draw some conclusions about, you know, what constitutes high intensity interval training and why do we see these different adaptations at the aerobic end of the spectrum when we compare that to resistance training. So I think that's pretty much all I have in regards to this stuff. And the take-home point is really untrained individuals can get a positive cardiovascular and aerobic response from just resistance training alone. So if you have a sedentary person come in off the street, you can feel confident that you're doing enough to improve those energy systems just with their resistance training intervention. Now, depending on what their goals are, right, and what level of fitness they want to get to, and all these other things, you know, it's up to you to kind of come up with an intelligent conditioning program if it's necessary for them, and it may not be, just to improve their overall quality of life and health. That's really where we're at, I think, in regards to the literature at this point, and now CJ is going to kind of take everything home and talk about how this stuff actually works out from a performance standpoint. Thanks, guys.